Episode 136, The Paradox.
Welcome to The Paradox with your attending, Dr. Eric Larson. He is a practicing anesthesiologist and clinical assistant professor at Michigan State University College of Human Medicine. Listen in as he takes you behind the scenes of what practicing medicine in today's ever-changing world is like with another doctor. The Paradox is a fun and accidentally informative show for physicians, patients, or anyone who has ever found themselves in a waiting room.
Welcome to The Paradox. I'm your host, Dr. Eric Larson. Thank you for joining me as we explore the U.S. medical system in a fun and informative format through expert analysis. And today's expert is just going to be me. We're going to be discussing a physician survey that came out recently, which I think is really important. It's one that impacts you whether you're a physician, very personally, or if you're not a physician, which is probably personal at some point because you're going to get medical care at some point. And we're going to look at the U.S. healthcare system. We're not talking about COVID today or any of that stuff, which we spent plenty of time in the past. We're going to go back and look at, in some ways, the effect of COVID on the medical system, but how that's affected physicians, what they're up to, and their attitudes. And this is a again, super important topic, and I want to get into this because I think it's something we want to not lose focus with, because there are a lot of things been going on in the last few years. Since I've begun the show, I've definitely become much more optimistic about the U.S. healthcare system, in the sense that although there's a third-party system, and it's one in which we have a disconnect between the consumers, those are the patients, and the people providing the care, hospitals, pharmacies, insurance companies, imaging, physicians, whomever. And in fact, the consumers are actually not patients, you and me, when I'm in the healthcare system. It's actually the people paying the bills, and those are the insurance companies, generally speaking, and then all the other people who make the payments in lieu of actual having the patient making the payment. And that's where we focus a lot about direct primary care, because that obviously is a direct relationship that we don't have in most of the medical system. And so we're going to look at what sort of trends we see in the larger system, and I guess, how things have been going. And like I said, I've been much more optimistic because in general, there are a lot of people doing innovative things within the healthcare space who are physicians, who are finding ways around the system. And even though it's a third-party system, they're finding ways to make it so it actually works for patients. For instance, direct primary care. Dr. Smith, who I've had on before, who has a freestanding independent surgical center that actually doesn't even take insurance. There's freestanding ERs. We talked to a lot of people who've left academics, or we'll call it industrialized medicine. Those are people who are in large healthcare systems and sort of struck out on their own, and they found different ways of delivering care for their patients, oftentimes at a greater value, much more rewarding professionally for them, and probably better care too. So anyway, we're going to talk about the overall trends and what's kind of going on in medicine. But let's run a quick ad from my friend Dr. Erin Wiseman to pay the bills.
Hey there, this is Dr. Erin Wiseman. I'm a fellow Doctor Podcast Network member, life coach, and mama 3. I kick butt, I take names, and I help other high-achieving people do the exact same. And today, I want to invite you over to my podcast, Dr. Me First. It's well over 300 episodes, and each one is filled with inspiration and advice from amazing guests. So grab your wife, your mom, your sister, your best friend, and come tune in as we explore what it means to be a woman in medicine and a woman in this world. Because this podcast is a dose of everything that I needed when I was burned out, exhausted, and ready to quit it all. At the end of the day, I do this to help you feel more connected to yourself and to connect with others. I love to end my show with a kick of encouragement, so here's my favorite tagline. Your life, your calling, your pulse matters. See you over at Dr. Me First.
Without further ado, let's just get right into it. We're going to specifically focus on the Physician Advocacy Institute. The Physician Advocacy Institute, you can find it at physiciansadvocacyinstitute.org. And they are a group that, not surprisingly, advocates for physicians, but it focuses primarily on physician practices and ways of sustaining physician practices and a way of avoiding conglomeration and consolidation of physician practices. And so they do surveys to find out how things are going for physicians, namely, how often are you getting employed? How much are you creating new practices? And how is your practice doing? They also advocate for physicians, which is the advocacy part of their their mission, and they look for ways that are to help physicians navigate the current healthcare space. And so what are the problems right now in medicine? Well, clearly ones with regulatory network regulations and things like that. And so how can we help you navigate those things and maybe advocate with lawmakers or whomever to try and make that better? So we're going to look at their survey they just put out. You've probably seen this on Twitter or Facebook, but it's the Physician Advocacy Institute. From June 21st, they published it of 2021. They did a survey along with Avalier Health, I think I pronounced that correctly, and they were looking at what's going on with physician employment. So essentially, there are two different ways you can look at a physician. One is you're not employed, meaning you work for yourself in some sort of manner. Either you work for yourself or you work in a group, but you're not owned by any sort of corporate entity. You are the ultimate boss of the organization. So you either own the practice, you own the building maybe you just own the supplies, you're renting out the space, but you are essentially not working for someone else. You're not cutting you a check, determining on your pay and, how much you get paid based on whatever criteria they set up. The other alternative is obviously being employed. Now, this could be someone in academic medicine, because people who are in academics are almost always employed by the university system they're in, or maybe a nonprofit healthcare setting, like, a Cleveland Clinic or, Mayo, although Mayo may be for-profit actually. But anyway, the point is that you're either employed or not employed. And so what are the overall trends? Anyone who's in medicine realizes a few things. One is there's been a consolidation in the healthcare space, meaning you're finding healthcare systems slowly getting bigger. They're not breaking apart. They're not getting smaller. They are, if anything, gobbling up smaller enterprises. You're seeing that initially with larger systems in urban areas that, they grab the county healthcare system that's one county over or something like that. Or you see hospitals within a city that merge together. And that happened in my city before I even started back in the 90s in Grand Rapids. And this is happening all over the place. It's nothing unique to Michigan or anywhere else in the country. But essentially what's happening is healthcare systems are getting bigger. Not only are they getting bigger, but they're also doing other things like not just having hospitals by each other, but they team with an insurance company, or they are purchased by an insurance company, or they purchase one, or they employ physicians, or they do all those. They'll get their own radiology services. They'll get their own imaging laboratories. They'll get all the vertical integration. So essentially, when you look at something like General Motors, it would be sort of like, we make the car, we make all the parts for the car, we make the tires, we own the dealerships, and we are from the beginning of the process all the way to the end. That'd be vertical integration. And so healthcare systems are increasingly becoming vertically integrated, meaning every aspect of your care, from walking in the door, seeing a doctor, getting your tests ordered, getting certain medications, and then who pays for it, and the insurance aspect, and then going to the hospital and getting surgery or whatever, and then getting to subacute rehab, perhaps afterwards. All that will be provided by one healthcare system. This is a trend nationwide. And so one large part of that is, of course, physicians. And physicians are an important part of it because they're the ones who direct patient care, generally speaking. So patients will take the advice of their physician and go to a certain laboratory, or they'll get a certain surgeon, or they'll get a certain imaging test at a certain location. And that's sort of what they'll see actually referred to another specialist. Like if you're a primary care doc, you say, oh, you should go to this specialist. And generally, if it's within a healthcare system, they try and keep it together in one place and prevent leakage, which is called when you refer outside of your network. This can also be put together more efficiently by having insurance companies that direct your care to within in-network services. And so you'll see that as well, where you see, you get a discount, or you have lower copays or something like that, or less deductible payments if you go to some physician or some sort of service within network. And generally the network is within whatever that healthcare system is. Like, you get through Blue Cross network, or say Trinity Health, which is a large one in the country. They may have some deal within that area where they get all your care in one place. This can improve efficiencies. And the reasons people argue for this sort of system is because, well, now we know that we're sending you to high quality care. We're making sure we can streamline the service, and everyone communicates real easily through our computer systems, all the same, or something like that. And so we can have a lot of efficiencies and prevent a lot of waste of time and resources trying to coordinate stuff. Now, as we know, that's not really what happens. We'll talk about that in just a moment. So the question is, what's happening with physicians? Are they employed or are they independent? And maybe this is surprising to people who are outside the healthcare system, but those within healthcare recognize that a majority of physicians are employed. And I think the most recent numbers are about 70% of physicians are employed by a hospital or by a corporate entity. And briefly to mention corporate entity, there are a number of practices that will be owned by a national specialty service usually, or a venture capitalist group. And so they'll sell their practice and they will become employed through some corporate entity, although it may not be a healthcare system. And so there are a number of, I'm in anesthesia, so a lot of anesthesia national services that will buy a practice, and we can maybe discuss that in a little bit. But essentially, you're either working for a hospital system or a corporate entity, and so those are sort of the two ways of looking at it. And what happened in the last 2 years? Well, there was COVID, right? In 2019, COVID sort of was just kind of rearing its ugly head in China. But by the time 2020 hit early in March or January, depends how you want to define when it actually started affecting things. Certainly in this country, the United States, it started affecting us in March and April significantly, especially within the healthcare services, where operating rooms were shut down. Hospitals became sort of ghost towns unless you were in the rare spots where there's actually large SARS-CoV-2 infections, COVID-19 hotspots like in New York, New Jersey, even in certain parts of Michigan, we had some, and maybe even Northwest in Washington. But for the most part, most parts of the country were kind of closed down and they had no business. And they were not allowed to do business by the state governments. And so their revenue went suddenly to zero. And if you're someone who runs a business, you recognize that if you're not making any money at all, you can't make payroll, you're not usually sitting on piles of money, you don't keep it laying around in case there's some sort of disaster, because that doesn't really happen in healthcare, except it did last year, right? And so what had happened is there was a continuous slow trend of more and more and more physicians becoming employed, hospital systems acquiring practices, or corporate entities acquiring practices. But that accelerated last year. And so just to give you an idea, from 2019 to 2020, so 2 year span, there are 48,400 physicians who left independent practice and went into an employed model. That's an increase of like 12% from previously. Just in 2020, after COVID hit in June, so halfway through the year, there's an increase of about 22,000 physicians who went into employed status, which is pretty significant for just a 6-month period of time. Hospitals and corporate entities acquired 20,900 practices, which was a 25% increase over what they'd had before. So just to give you an idea, there are a ton of physicians who left independent practice, became employed. They sold their practices or they were acquired, sometimes under distress. Previously, to give you an idea, I can't post a graph here, an audio version, but in January 19th, there were 61,900 physician practices that were owned by hospitals, so 24.3% of practices. And this is, even though most physicians are employed, you have to recognize that lots of physicians have solo practices. And so 24% of practices, if a lot of those are solo practices, the majority of physicians still can be employed, even though a minority of practices are actually owned by the hospitals. That makes sense. So anyway, in January of 19, 61,900 practices, or 24.3% of practices, were owned. By July, it became 24.6, so minor change, 0.3%. 6 months later, January 20th, 24.8%. July 20th, July of 2020, there's 63,100, so we've already gone up almost 1,400, so 25% of physician practices. And then in just another short 6 months, we went up to 26.3%, or another 2,000 physician practices in 6 months. So greatly accelerating the speed with which practices were being acquired by hospitals. And if you look at corporate acquisitions, pretty much the same too. You see going from 37,200 in January 19th, January of 2019 at 14.6%. Then you go up to January of 2020, you have 16.8%, so significant. So from 7,000 to 42,000 about. But then July of 2021, January of 2021, you have 54,900. So in the span of basically 2 years, you've increased 17,000 practices owned by corporate acquisitions. So you've gone from 14.6% owned to now 22.1. So that's significant, right? I mean, you've almost doubled or about 33% increase in just 2 years of the amount of physician practices were acquired. This is not unique to any region. So the Midwest, the South, the Northeast, the West, Pacific West, and the Mountain West, they're all the same. You saw the same trend everywhere. Maybe you saw a little bit more in the South than you saw in other places, but essentially it was pretty much across the board. It didn't seem to matter where the payers were. It didn't seem to matter where you were. That was the overall trend, is that physicians were moving to employed status, and either with a corporate entity or with through a hospital system. So the questions, I guess, really are, why are physicians doing this, right? So let's figure that out first, and then figure out whether it's something we need to worry about. So why do physicians sell out, right? And that's maybe not a fair statement, because a lot of physicians are employed, and it's not selling out. It's the sense that you've sold your practice and you've now moved to an employed status. So why do you do it? So one is you cash out for retirement. So if you're a couple years away from retirement, let's say you have a solo practice, or there's just two of you in the practice, and you're nearing the end of your career, and you're looking at saying, well, we've built this big thing. We haven't really tried to recruit. We could recruit someone and sell our practice to the next person, or sort of bring them in as partner. Or we can just sell this thing, which is probably worth a lot of more money. And this hospital is willing to pay us, a couple $1 million or something for our practice and for our patient panel. Because hospitals don't care so much about the physician, but what they really care about is the patients that are attached to that physician. So if you're a primary care physician and you've got, 2,000 families that are with you, you're valuable to that healthcare system, because if they look at that and say, well, we're only capturing about 1,000 of those families, 1,000 of those families go to another hospital system across the town, it would be very helpful for us to purchase this practice. And that way we can guarantee that we're going to get almost all those 2,000 families if we bring them into our network. And so that's what happens, because they assume that if they have the physician, they capture them, then they will be able to get that revenue, and they'll be able to increase their market share. Docs also go into employed status because they can avoid this overhead. Sometimes running a practice is a pain in the butt, and there's a lot of stuff we don't learn in school. We may not enjoy running a business. We may just like doing medicine. And this gives us an opportunity to just do medicine and to not have to worry about all that other stuff. And I hear that all the time when I talk to lots of my colleagues who are employed. Markets swing up and down. It's hard getting business sometimes. And if you have a hospital system that is backing you and guaranteeing a salary, you don't have to worry about that quite so much, right? If there's a market downturn. Now, in reality, of course, we saw that this is not the case. With COVID, you saw swaths of nurses and certain specialists just get dumped to the curb, replaced for people who are cheaper, or just because there's not enough business, like in, say, the emergency departments. And so you saw that that's not a real security, but it's one that's perceived. And so, you see the guy who's got a couple $1 billion, you're definitely a lot safer than you've got just, making a couple $1,000 over payroll every month. Physicians also have tremendous amounts of debt, especially they're coming out of school. You're going to come out of school with about $250,000 of debt. That's tough to make up. There's that big brother next door who's got a pile of cash that's about $1 billion to get a lot of it, slush funds from the government. And it's sure a nice way for them to guarantee that you'll pay off your debt. Now you don't have to worry about that so much. So that's definitely something you see people go for. It's also stable, like I mentioned before, stable, reliable income. So it's real easy to justify going to some place because you don't have to worry about the spending. Every year there's more and more regulatory burden and reporting problems, whether it's through Medicare or value-based care. It just becomes onerous. You almost have to hire extra people to do this. You already have to hire people to do your billing, to do your coding, transcription services. And so now it's just an added layer as the regulations always increase. They never get lower. And so it's just harder to manage that stuff. And so it encourages you to go and sell your practice. Electronic medical records cause a tremendous shift in the practices that they were forced to now go into, well, frankly, sell their practices, because the cost for an EMR is really great. One, there's training time. Two, you've got to actually learn how to use it and maybe make it useful. Three, does it even actually work and make it helpful? We've talked many times about this, that electronic medical records are rarely ones that improve your efficiency. Also, you find that the electronic medical records are incredibly expensive. We're talking about products that cost $800-900 sometimes per provider per month. And so that's, if you have a PA with you and then you've got a doc and let's say just the two of you in a practice, you're shelling out over $1,000 a month just to pay for the record. So that's $12,000. If your efficiencies decrease because of this, or you're spending more time charting, clicking, and stuff like that, you can see how this becomes really onerous. And then if there's problems or maintenance issues, you got to pay extra sometimes for that. So it can become really a big problem. And does it communicate with your scheduling services and other parts of your practice? If not, then you've got to find someone to integrate that, and that's an additional cost with IT that you didn't have before when you just had pieces of paper. And there, of course, are audit processes. There are people who are checking up from the government saying, are you actually overbilling? Are you underbilling? We got to go through this, and we want you to verify and prove that you're not upcharging, which means you're charging more for a visit than you should. And this, of course, comes with any payer, but especially problematic with the government. And that's, again, an additional charge or cost that you have to have someone doing things. And so there are a lot of headaches and things that are not medical related that physicians just rather not deal with. And I totally understand. And so that's why a lot of them just decide to go employed. Especially, you can imagine someone beginning their career, lots of debt, want a stable income. The last thing you want to do is go out and struggle and be poor for another 3-4 years and you're trying to get a practice started. Or you're someone who is at the end of your career and you're like, well, I'm just going to cash out now. I could sell my practice to someone, but it's kind of hard. And I can just sell it out, kind of just coast in the end of my career. The hospital system knows they're getting kind of shafted a little bit but they feel, well, we're getting the patients anyway. So we may get someone who's not working really hard, but we'll at least get his or her patients and to make it worthwhile for us. So that you see that. Those are the reasons why physicians do it. And I think many of these, whether you're a physician or not, you can kind of see that make sense, right? But the other question is, why do we care? Why is this a problem? Why does the Physician Advocacy Institute exist? Why are there people who are worried about a lack of independent physician services? Because in some ways you think, well, is it better having 10,000 independent pharmacies, or is it okay having 7 competitive, large, multinational, or at least national pharmacies? Maybe that's just as good. Maybe it's better off. There's some efficiencies with scale. You can have less executives. You get bulk discounts and things like that. Well, what we found through this process in the healthcare system, and not surprising to anyone who's actually gotten care or had to pay for the care, is that the more consolidation we have, the less pressure there is to keep costs low. And so costs tend to go up when you have less competition. I mean, I guess that's kind of obvious, but the efficiencies that are gained are rarely ones that are transferred or carried over to the consumer, whether that's the employer paying for the bills or whether it's the patient. And so essentially you have people paying more for healthcare and not getting better care. They're just paying more for it. And so the more you have consolidation, the more you have these large healthcare systems growing together or adding hospitals or adding physician practices, it just becomes, there's less pressure on a healthcare system to keep costs low for obvious reasons, because they capture more of the market. And so if you have more of the market share, you have less concern about your competitor. There's also less innovation. And this is maybe one that's maybe not as obvious, but it should be if you think about it. So you may have a healthcare system that finds a really great way of doing something. And there's no question this happens all the time. You have very smart people like academic medicine or large private practice, and they can do large studies of their patients. They can, figure out best practices for getting people in and out of the operating room quickly or treating some sort of problem like pneumonia or pancreatitis or something like that. And they can find better ways of getting people in and out of the hospital through their large numbers. They can test and say, oh, it turns out, or they talk to each other as colleagues and say, hey, I figured out this is the best way of doing things. And they can set algorithms and they can set standards to improve those things. And that absolutely does occur. But it's also very easy for someone who's an independent doc to see those same studies later, maybe like a month or a couple months later, and adopt them also. But additionally, if you have 1,000 people attacking a problem, you're much more likely to find people who are innovative and find really exceptional ways of solving problems. Yes, there is an advantage of having large groups doing these things and instituting, maybe doing a study large enough to find the problems, find the solutions. But having 1,000 people trying to work on something generally finds a better solution more often than not. And having those people who are looking for ways of saving money for their patients, finding alternatives for treatment, or sending people to different, say, pharmacies, or they're sending them to different imaging centers. They're creating a competitive environment in which it forces everyone to provide better care for less money, which is what we have most of the time in a market economy. And so having more people around improves those things, and it's going to make it more innovative. More people are going to be likely to try different things. Some of them will fail, but some of them will be very successful and actually provide better care. You also see prescription drug prices are going to get worse because you have a consolidation of these healthcare services. You have pharmacy benefit managers we've talked about in the past many times. They will come together and they will dominate more and more of the market. They'll have a greater control on the insurance companies and sort of the tiered way you get your medications or the way you're supposed to be prescribed them. And because of that, it's going to make it much more expensive, and you're going to have less options. And so you're going to have worse pharmacy benefits, and you're going to have, and it's going to be more expensive. So that's a fairly obvious one. Again, most of these are sort of anti-competitive things, but let's talk about some other things that are probably more important to physicians specifically. Your autonomy is worse. There's no question that if you run your own practice, you have autonomy. You can choose how you run your practice, what you do. You're clearly limited by what you can do by your payers and those sorts of things. And so there are people who are telling you have to do certain things in order to meet certain metrics with like Blue Cross Blue Shield or someone else. And so there's no question that there's an importance in following certain rules. And so you don't have absolute autonomy. You can't just practice medicine however you want. You are limited by the insurance provider. However, the way you meet a certain metric, there might be 50 ways you can meet that. And you find the way that works best for your patients and with you. And maybe you have 10 different methods because you have 10 different types of people. Some people respond to certain incentives and others don't. And so you have ways of sort of handling those things. If you're in a large system, you don't have that autonomy. You're also practicing kind of the way they want you to practice, whether do they want you to see lots of patients? Do they want to make your referrals certain ways? Do you have to refer within the network? If you refer outside your network, like you say, you need to get an MRI and our MRI is backed up for the next 2 weeks, go across town to our competitor and get an MRI there. Well, that's not going to look very good, and you're going to get penalized for that. And people, without a doubt, get penalized, and they say that it doesn't happen, but it absolutely happens. So don't believe anyone who tells you otherwise. And then the other aspect is there's an easy encroachment for non-physicians to provide care. Now, if you're a non-physician, I totally get it. It's fine. And I'm not someone who's going to tell you that you shouldn't see nurse practitioners, shouldn't have PAs, nurse anesthetists, physical therapists, whatever. I'm not someone who says that people can't get the care from that way. However, if you are a physician, there's every reason to be concerned that when you become employed, you definitely become more of a widget than you do of someone who leads a care team. Who is a decision maker, who's someone who's a leader within the organization. They may tell you are, and you might be, sort of, but essentially it becomes pretty obvious that the healthcare system is going to look at those other providers, and I'll call them providers because that's what they're calling everybody, as equivalent, except that they're not equivalent because they're a lot cheaper to train. They're easier to hire. There are way more of them. And with the scope within the most states and licensing, they can do pretty much everything a physician can. Now, there are certain things they can't do, but it's shrinking all the time. And when you look at the training levels, they're definitely different. And so we can talk about who's safer or whatever, and I don't want to get into a discussion at this point. I've done things on nurse practitioners before, and there are plenty of other people who've talked about this. But if you're a physician, you absolutely have to look at the fact that if you are employed, your value within the organization as a physician is much lower than if you're an independent physician. There's no question about that. Hospitals will look at you much differently if you're an independent practitioner out in, the community, and you're not part of a health system. They'll be much kinder to you and do everything they can, go out of their way to get your business to make sure that you refer your patients to their health system. Then if you're within the system, they're not going to treat you the same. And I don't think there's any way you could deny that that's the case. Overall from a corporate standpoint. And that would be absolutely crazy if they didn't do that way. I mean, that's why you employ people, so you can control them and have them sort of practice the way you want, whatever your goals are for your organization. So if you're worried about the encroachment of scope of practice or mid-levels, you should absolutely be worried about employment in general, because naturally you're going to be seen as equivalents. They're going to have those people do as much as they possibly can within their license, and that is increasingly becoming more and more. And so if you're a physician, you care about that sort of thing, then you should be concerned about the employment status. And then finally, your pay is going to be pretty stagnant. It's not going to increase that often. Now, I think you could argue this is probably the case out in independent practice too, and there's probably a lot of truth in that. I think most physicians would say their reimbursement's not really gone up in the last couple of years. It's certainly not keeping up with inflation, even though inflation's really low, and the costs go up and pay is kind of about the same unless you do more work. But you don't take any risks when you're within an organization, and so any innovation you bring about, you're not going to get any of the value from that. And I think, when I talked most recently to Dr. Diana Bittner, I think that was a great example where she had all these innovative ideas, ways of treating her patients and providing care for women in approaching menopause or perimenopausal area. And there was a lack of institutional support at times. They just said, you know what, it's not worth it from a financial standpoint, which it probably wasn't for the institution. And so they just said, we're abandoning it. So not only did she lose her not having autonomy and sort of directing, how patients caring for them the way she wanted, but she wasn't allowed to take risks, and her pay, didn't matter. She didn't get paid more by being risky, and large institutions generally don't like to take risks. And it also speaks to the fact that there's less innovation because of this, for this reason, because there's not that risk taking that goes on with the employed physicians. So we have a situation where we have recent laws in healthcare. Obamacare is a big one, or the Affordable Care Act, what do you want to call it, that definitely encouraged with electronic medical records. That came with also the HIPAA provisions, which encouraged electronic medical records in general, because it was designed, as you look way back in my episodes, you can go back to find an episode on HIPAA, which I think is really interesting. It wasn't about privacy. Everyone talks about privacy, but that was a minuscule part of that law. The primary objective of HIPAA was to get people to use electronic records and to facilitate the transfer of patient data from institution to institution, or like from one entity to the next. It was for the Health Information Portability Act is what it really is. There is privacy in it, but it's mainly for health information portability. So it allows your data to go out to whoever is buying it from whatever entity that it is. If they have really solid security, they can access it. There are millions, I think like 2 million different vendors who can get your data much more easily than you could, which is really kind of crazy. But that's what HIPAA is about. But essentially, we have that, which brought in the electronic medical record as well in order to make this portable. That caused ways where it's hard for physicians to have a practice. Then also you have the other problems with things. With the Affordable Care Act, it caused a lot of money going into hospitals. You have a mismatch in care. And so you'll find that doing an echocardiogram is paid out at 0.7 at an outpatient facility, or it's paid out at full amount if it's in a hospital or a hospital-owned outpatient facility, which makes no sense, except it, of course, benefits the hospitals. And so people who work for the hospital are going to make more money. And you take a pay cut by doing it independently. So now you have added costs, added regulations, and then you get decreased reimbursements. It makes a difficult decision to stay independent. You have to really want it, and you have to really want to do with the hassles and try and find ways to gather efficiency somewhere else in order to make up for the pay cut. All these things contributed to the employment of physicians. Also, costs of medical education. Then you add in COVID, which happened last year. You had a period of time for 6 to 8 weeks where practices were devastated. In fact, many practices, even though they got back to work, they really weren't very busy because people weren't getting sick, because people weren't going out. And so you're kind of used to a certain level of illness because we're designed to take care of people who are sick. If people aren't going out and doing anything, they're not getting sick. And so if suddenly you've lost 50, 70% of your revenue and your overhead's already 70%, you're basically trying to fund this, not having any money, or you may not be able to make payroll for your physicians or your staff. And so now you're in trouble. And we saw that a lot. There was definitely loans that came out from the government, the PPP loans, which helped a lot of practices, but that wasn't known for sure if it was going to work out initially. And then if you're someone who's kind of been on the fence, like, I don't know, maybe at some point I'll sign on with, the hospital X across town, but I don't know if I really want to do that because some of my friends who've done that, they don't seem quite as happy or whatever. And then you have COVID hit and you're dealing with more overhead, and then now you have to deal with this loan, and how does it actually work? No one really knows because it was like months before there was any sort of rules to come out about it. And so you're like, yeah, you know what? I'm just going to sell. Or a venture capital group comes and they want to purchase you, and you're like, yeah, makes sense. I think I'll do that. And so that's what you saw a lot of. And I think that's why you see an acceleration of it. Now, will this change this year? I think that'll be an interesting question to see if this trend is sort of, will continue that same slope, or if it'll slow down. Maybe it'll go back. I don't know. But there definitely is something to be concerned about if you're a patient or if you're a physician. I think the loss of independent physicians is a big deal, much like it would be a big deal if we lost all independent grocers and we had just gigantic chains, or if all we had were Walmarts and Amazon to do for all our sales. It's not that they don't provide a good product and they don't provide good service, but that if you don't have any sort of price pressures or innovation within the market space outside of what those large carriers are, then you're going to have some problems with costs and probably service. We see this all the time with cable companies. I had an interesting experience with my cable company, Comcast, and they've been, you call Comcast for repair and they come back. They say, we'll be there, in 4 days, and you have to be home from 8 to 5, which no one can do if they actually work, right? But we had the occurrence where we had a problem with our cable. We noticed it, like, our internet's not working right. And there was a guy who came out to our house ahead of time. This never happened before. But now there's a significant pressure on Comcast and other cable providers. They've got, internet Starlink coming up pretty soon. They've got all sorts of different possibilities of getting your internet data, like through cell companies. And so they're forced to be innovative or actually be responsive where they never had to before. And so I think hopefully we'll see that in healthcare, that we'll start seeing a reversal, and that we're going to have more people enter the space and provide competition for those who are already in the space right now, the large players. Because the one thing they don't have is they're not able to be nimble, and they can't be nimble. They can't be innovative in general, because that's the nature of anything that's big. It can't turn around quickly. Their advantage is that they're big. Their disadvantage is that they're big. It's sort of like the advantage of being a nimble, small company is you're nimble and small. The disadvantage is you're small, right? and you can't get the capital and resources to maybe make the things you need, the changes you need to do. But that's always the give and take with any sort of business. But you need to have a robust, large business, small business, medium businesses, right? I think you need all those in order to have a really healthy healthcare system, which we don't have at this time. And we've talked about a number of other problems like the third-party payer system, et cetera. But in general, I want you to keep in mind, if you're a physician, I'd love to hear stories about how you've maybe dealt with this. Am I just totally wrong with my employment analogies? I think my assessment's pretty close to on. I don't disparage anyone for making those decisions. I'm in a single specialty independent group right now. That could change tomorrow, but I don't think it will. But anyway, there's always pressures we all have, and it's just interesting to see how it happens. And I think I want people who are patients or in other affiliated healthcare specialties to recognize what's out there and what risks there are that physicians face. And I think it's in our best interest to have as many of these voices and different practice models. Just like direct primary care is a great choice, but it's not for everyone. I wouldn't want everybody to do one thing or the other. I want them to find sort of the path that works for them. But you need to have options. And the less options that are out there, and the less people who have experience doing a certain thing, you're just losing a little bit of that knowledge, and less likely people are going to go into that sort of specialty. So we need to not force people into certain models. And right now there's a huge push, whether it's intentional or unintentional, through large legislation and to make everything bigger in healthcare. And I think it's to the detriment of both physicians providing the care and especially to patients who are ultimately paying for it in some way on some level for healthcare, and the ones receiving the care that's not quite as innovative, maybe not getting the kind of care they want from the people they want. So I think small is good. It's not the be-all, end-all, but it's important that we have those voices and we have that ability. So please write me. I'd really be interested in what you think about this summary. You can reach me at the Paradox Show at protonmail.com. So I'm trying to remember my email. So get back to me, as I love to hear from you. And if you like this message, if you like what we're talking about in the show, and if you like their analysis, I'd really encourage you to go to Patreon and support the show there. Your donations to just support the show on a monthly basis would allow me to start some videos and now get more production and promotion quality videos and the show, which I'm still working on, and I appreciate that and your patience. But you're what make this show so popular and so successful. I'm reaching so many more people than I ever thought I would, and all over the place in the United States and even outside the country. And I owe that all to you, and I want to thank you for that. But if you would like the show and you want to keep it going, I'd ask you to just go to the patreon.com/theparadox, and there you can just make a small or hefty donation, whatever you want. And there's some extra bonuses if you want as well. I'll send you some stickers and some stuff. But anyway, patreon.com at the paradox. So patreon.com/theparadox. And I hope I'm bringing the content you want. If you ever want something, please get back to me. And I'm always looking for new people to interview and new subjects, because there's just so much out there in healthcare that I think is really interesting. Thanks a lot. Also, don't forget to hang out with my friend Dr. Erin Wiseman at her podcast, Dr. Me First, on your favorite podcast app, or learn about more how to connect with her at the Queen of SaaS by heading to drpodcastnetwork.com/drmefirst.
Thanks for listening to The Paradox. If you like what the doc is doing, please subscribe and leave a review on iTunes or Stitcher. And share the show with your friends. Become a supporting listener to get access to special bonuses at patreon.com/theparadox. Show notes can be found at theparadox.com.